chiamo Michelangelo Gangemi, che ci parlerà di indicazioni e problematiche nel trattamento.
Now we're going to hear from the next speaker, who's going to talk about malformations in Chiari 2. Thank you. I'd like to thank Dr. Valentini for this very interesting congress. And in fact, this is proved by the very wide debate that we're having. We're going to talk about a completely different subject compared to Chiari 1. For many, many reasons it's different, but I think nonetheless it's a valid subject, especially since Chiari malformations seen in patients with myelomenincocele, which means that today we don't have just a pediatric but now an adult population with the problems that we all know and that which should be looked at. I don't have the difficulty that all previous people have had in labeling this pathology, because type 2 malformation, as Chiari has described it, is a well-identified disease and sees the descent of the cerebellar components in the presence of myelomenincocele. And we have to go back to the history, of course, before we go to Uncle Chiari, as he was named before. Now, Grandad Cleland first described the malformation, and then Chiari described the 4 groups that we are now trying to add to, with some difficulty, however, in understanding the breadth of these groups. However, Arnold, in fact, has unjustifiably associated his name to Chiari. He was just a colleague, but he described a case after Chiari's definition. I think we should, however, recall this colleague, who in 1932, in his dissertation thesis on hydrocephalus, he suggested craniectomy to treat Chiari's syndrome. Pathophysiology here too. Let's go back to this a little bit. Cleland was the person to discover it, and in dysraphism he saw the first signs, and then Chiari saw hydrocephalus as being the cause of the malformation, and this theory of Clary's became very widespread with Gardner, who for many years upheld this, and this was the accredited definition, and Penfield, that you know for other reasons, was the first to attribute the cause of Chiari and meningocele. He attributed to tethered cord, and then a disproportion between the volume of the posterior fossa, cranial fossa, and its contents was seen as being the cause of Chiari, because there was a continual CSF flow, and this led to the lack of development of the posterior fossa, and hence Chiari. Then David McCroon summed this all up, and I'm not going to go into McCroon's thesis, you all know it, but the disorder, the primary neural disturbance for him is the reason for all the symptoms. The clinical presentation of Chiari 2 has to be differentiated depending on whether you're talking about very young children under 2 or older children. In patients under 2, symptomatology is dramatic very often, and the brainstem and the rapid development of symptoms is clearly seen, and this differentiates this condition drastically from the more mild and nonetheless very often dangerous situation that we see in the older child or in the adult. So the two types of situations call into question what sort of treatments, if they're different, who should be operated on, when, and how. What are the patients to treat? We said before there's no discussion with regard to the patients that develop the symptoms that you see on the slide. They have to have decompression, and it becomes an emergency surgery. And again, when you can link up the symptoms of the infant directly to the malformation, indication for surgery is obvious. The problem, however, arises, and I hope that this will be the core of our discussion, is what to do with symptomatic patients. The observation of this sort of patient is a very particular one, because they are patients who already have been operated on for the spinal operation and for the associated hydrocephalus, and then they're observed. They're patients who progressively develop syringal cavities, but who, at least in the literature, really don't have any preventive surgical indications. But we know that this is something which is going to develop, because in fact there are two different attitudes vis-a-vis the Chiari 1, where we have a malformation which probably will progress, but Chiari 2 definitely will progress in time. And perhaps our view is somewhat clouded, or limited, if you like, by the fact that we have patients who are severely affected by their basic condition with hydrocephalus and myelomeningocele, first off. So we either tend to be interventionists or non-interventionists. Preventive surgery is only slightly talked of, and I must admit that I don't have a clear idea myself as to whether preventive surgery is in order for these patients. But anyway, this study here tried to put forward as a candidates for surgery, or probable candidates for surgery, it was said those patients where the cavity is more than 50% of the diameter of the spinal column. So the second question is, when should these patients be treated? And here, unfortunately, the literature has nothing on timing, because patients are surgerized as soon as they have symptoms, even if we know that preventive surgery probably would be the only way to, in fact, ward off syringomelia. So this attitude that we take perhaps is not that justified, because when you have a patient who's now an adult, we're no longer talking about children, in fact, or we're talking about older children. When a patient starts to present conditions and disorders because of this syringomelia, we know that in the vast majority of cases, surgery can, in fact, stem the symptoms, but in fact, it won't allow the patient to really recover. And you have to bear this in mind. And how to treat them here? It's very simple, the answer. Certainly you have to consider the other pathologies that these patients have. Myelomeningocele, the treatment here is done in the first few hours of life, and very often it's called tethering. Very often these children have a tethered cord and hydrocephalus. As we've heard for Chiari 1, this is all important, and it's all important to the development of a syringal cavity. And decompression technique, well, this doesn't differ really from what is done for Chiari 1, and this has been widely described before, except perhaps in terms of extension, the laminectomy, and the need to carry out duroplasty. I think in Chiari 2, duroplasty is essential in all patients. Anyway, before you go to surgery and decompress in Chiari 2, in my modest opinion, humble opinion, I think you must consider, as I believe is logical, that the symptomatology is not due to poor shunt or hydrocephalus if it's treated arthroscopically, can't be managed. And because the symptoms of a poor shunt, in fact, are the same as the others. So you have to look at the hydrocephalus first and see where it comes from. The surgery, there's very little to add here, except that, as you know, very often we find at the hinge, at the joint, we see a wide area laterally extended of the lack of bone, and so when you cut the ligament you have to be very careful because the space is very large and you can in fact harm the dura. Another important aspect to take into account in treatment of Chiari 2 is the very low incision both of the trochanter and the two transversal signs, which limit your possibility of extending upwards this laminectomy. And I agree with the colleagues who preceded me. We have to extend as much as possible laterally, both in terms of the occipital foramen up to C1 and C2 even, bearing in mind also that if we're talking about a pediatric patient, the position of the two vertebrae sometimes is anomalous, so you have to be very, very careful when you go in. The arachnoid by and large is different to Chiari 1. In most cases we find a normal arachnoid in Chiari 1 that we try and preserve. In Chiari 2 it's always profoundly thickened and altered, and this is the only difference. Removing the arachnoid, which I think should always be done, this lengthens the time of surgery somewhat because you have to be careful and you can in fact harm vasculature, and this will cause subsequent adhesions, so you have to be very, very careful when you remove the arachnoid and to reveal the obex of the fourth ventricle and carry out duroplasty, which is very wide, to try and give as much space as possible. Now, this is a surgical procedure which has complications. These were recorded before for Chiari 1. The risk is greater vis-a-vis Chiari 1 in terms of pseudomeningocele being formed, but by and large, if you like, the complications are matchable. Fact is that treating these patients, we have severe scoliosis as well. It's not just scoliosis which is caused by Chiari 1, and surgery, therefore, for posterior decompression must try to destabilize, not destabilize a spine which is already highly destabilized. The other thing is, I think somebody talked about it yesterday, but is the possibility of the bone regrowth, especially if we have small children, and therefore the same pathology can reform again. Very often it's the adhesions, the fibrous adhesions which form under the dura magra, which once again cause the crowding and the narrowing the area of the atlas. What's the conclusion? I don't really have one, nor have I been able to find one in the literature. On the one hand, we have the problem if we do things too soon or too late, before the appearance of symptoms or after the symptoms are frank. And then the other question, of course, that one asks is, if you do this, do you do too much or do you do too little? So it's with these questions that I'd like to show you the last case that I operated on 15 days ago, a little girl with meningocele. She was followed up annually for spina bifida, with all the normal tests, and after a year developed this syringo bulb with deficit of the cranial nerves, which was severe despite decompression. Today she has still got symptoms. Thank you.
C'è qualche